Just a review, coronary artery disease is the most common type of heart disease. It is also called coronary heart disease or ischemic heart disease. So these terms, CAD, CHD, or ischemic heart disease, IHD, can be used interchangeably, and they pertain to the same clinical scenario, which is an obstruction or stenosis of the blood vessels of the heart or the coronary arteries. And as mentioned, it is caused by plaque buildup in the walls of the arteries that supply blood vessels of the heart or the coronary arteries. Now, this plaque buildup can also happen in the different parts of the body. For example, in the carotid arteries, in the arteries of the brain or the cerebrovascular arteries, and the peripheral arteries. So same mechanism of plaque buildup or atherosclerosis can happen in any artery of the body. The usual symptom of a coronary artery disease is chest pain or discomfort. And this chest pain that is caused by fixed obstruction of the coronary arteries is called angina, because there are different forms of chest pain. There can be anginal chest pain, which is because of CAD, or there can be a non-anginal chest pain. So we are talking about angina, which is the chest pain or discomfort that is afforded by fixed obstruction of the coronary arteries. And this chest pain or angina is the most common presentation of coronary artery disease as well. Now, there are others atypical or less common symptoms of CAD, which is pain or discomfort in the shoulders or the arm. And in other patients, especially the elderly or diabetic patients or female patients, they usually present with shortness of breath, even in the absence of chest discomfort. This is a diagrammatic representation of how plaque buildup can happen in the coronary arteries of the heart. Now, in the left panel or column of the left diagram, we can see that lumen is, or the inside space of the artery is free of any disease. There is no plaque buildup or cholesterol adhesion in the walls of the artery, and therefore there's normal blood flow. But on the right column, we can see that there is plaque buildup or atherosclerosis that is causing a reduced blood flow because of a reduction of the lumen of the arteries of the heart as well. Now, this is the main reason why there is a narrowing of or blockage of coronary artery of the heart and produces symptoms of angina, because there is a mismatch of the supply of oxygen because of the reduction of the lumen where the blood can flow and the demand of oxygen of the heart. And angiographically, this is how it looks like in the angiogram, where we can see that in the LAD, or one of the arteries, left-sided arteries of the heart on the left, we can see that there is approximately 70 to 80% reduction in the opacity, or there's 80% narrowing in the mid portion of the left anterior descending artery. And on the right side, we can see that there is a total blockage of the right coronary artery here, and the more distal portions of the blood vessel is visualized by collaterals from the contralateral artery, specifically the LAD. It is important to know that this is how we visualize coronary artery disease in the cath lab as interventional cardiologists. Now, as I have mentioned earlier, angina pectoris and CAD, there is the chest pain or angina is caused by a mismatch or of decreased oxygen supply because of the narrowing of the lumen of the arteries, as seen here, because of the atherosclerosis, and there is an increased oxygen demand or the workload of the heart. Therefore, our treatment for the angina should be targeted towards improvement or decrease of this mismatch. And we can increase oxygen supply hypothetically and decrease also the demand. Now, nitrates are the mainstay of treatment of angina because they cause vasodilation or venodilation, and this increases the blood flow or oxygen supply to the coronary arteries by increasing the diameter of the blood vessel. And also, they reduce the preload, which reduces the oxygen demand, which in turn decreases the workload of the heart. So it addresses both the mismatch. There would be increase in the blood flow, which improves the delivery of oxygen to the coronary arteries. And also by reducing preload, it reduces the workload of the heart. Now, the FDA approved uses of nitroglycerin is actually um, not primarily for hypertensive crisis, but for the relief of anginal chest pain in the setting of acute coronary syndrome or ACS. But other indications of the use of nitroglycerin is hypertensive urgency treatment or emergency in the setting of ACS or pulmonary edema, cardiogenic pulmonary edema. Some off-label uses include the treatment of coronary artery spasm. Coronary artery spasm is a phenomenon where there is a dynamic obstruction or dynamic reduction in the lumen of the coronary artery spontaneously without fixed obstruction. And another indication would be the treatment of angina secondary to cocaine use, and of course, cardiogenic pulmonary edema in the setting of congestive heart failure. We can use nitroglycerin. We have different dosing solution of nitroglycerin. Um, the most common dosages or the solution would include the 10 milligrams that we dilute to 90 ml of D5 water or sterile water for injection. In some clinical setting, we can dilute it in plain SS as well. We have the injectable solution that has a concentration of 1 milligram per ml, so that would have a 10 milligram per 10 ml. And some other dosage forms, such as the sublingual tablets, the oral tablets, the sprays, the transdermal patches, the gels, and of course, the IV and the intraarterial or even intracoronary administration. I haven't seen gels as well as the sprays of the nitroglycerin, but the other dosage forms I was able to use them in my clinical practice. This is an example of the IV form of the nitroglycerin, where we have a concentration of 1 milligram per ml or 10 milligram per 10 ml of the solution. I would like to highlight that nitroglycerin um, action is afforded by its conversion to nitric oxide inside the body. Then the nitric oxide activates the enzyme guanylyl cyclase, which in turn converts the enzyme guanosine triphosphate or GTP to cyclic GMP or guanosine 3,5 monophosphate in the vascular smooth muscle and other tissues. Now, cyclic GMP is very important because is it is the most important enzyme in the phosphorylation of different ultrastructure that I will show to you later, which enhances the reuptake of it phosphorylates the Surca pump in the smooth endoplasmic reticulum as well as the myosin light chain kinase, which causes relaxation of the smooth muscles within blood vessels, resulting to vasodilation. This is a diagrammatic representation of the mechanism of action of nitroglycerin. So nitroglycerin is absorbed inside the blood vessel, and it is converted by two mechanisms. It can be decomposed by or catalyzed to nitric oxide by the enzyme mitochondrial aldehyde dehydrogenase, or it can also be converted to nitric oxide spontaneously without enzymatic decomposition. And when it is converted to nitric oxide, it can go to the smooth muscles and blood vessels directly without any uptake or pumps that is needed. Inside the smooth muscles, nitric oxide, again, to emphasize, it activates or it causes the conversion of the GTP, guanosine triphosphate, to cyclic GMP, which causes the phosphorylation of the different ultrastructure inside the smooth muscle. Two of the most important pathways is the Surca pump. If phosphorylated, there will be a decrease in the active uptake of calcium into the sarcoplasmic reticulum. Therefore, there will be a decrease. There will be a decrease. Sorry, there's emergency. There will be a decrease concentration of calcium inside the smooth muscle cells, and also phosphorylation of the myosin light chain kinase decreases the interaction of the myosin actin interaction, which causes relaxation of the smooth muscle. So decreased intracellular calcium and decreased myosin actin interaction would cause relaxation of the smooth muscles, causing vasodilation. The uses of nitroglycerin is for angina is IV nitroglycerin is we can use it if they are intolerant or unresponsive to sublingual nitroglycerin. And it's the onset of action would be we can start the dose with 5 microgram per minute. And if unresponsive, we can increase by 5 microgram per minute every 3 to 5 minutes up to 20 microgram per minute. Then we can further increase it by 10 microgram per minute. But if it's still unresponsive, we may later increase it to 2 times the maximum previous dose, which is another 20 microgram per minute. It is important to note that if the infusion is uninterrupted for 24 hours, it can produce tolerance or the decrease in the effect of the IV nitroglycerin or increasing the dosage that would give us the same effect of the previous dose. So we have to provide a 10 to 12 hour nitrate-free interval for us to have the same effect of the previous dosage. Nitroglycerin is contraindicated in if it is administered with certain medications such as the following: avanafil, bromocriptine, cabergoline, and certain medications that is used for pulmonary hypertension or erectile dysfunction for that matter, and other listed medications here in the slides. Now, the adverse effects are the most common would be headache because of the vasodilation of the blood vessels of the brain as well. Hypotension, which is dose related. Tachycardia, which is reflex in nature. Other causes would be dyspnea, dizziness, lightheadedness, blurred vision, flushing, nausea and vomiting, and xerostomia. And other more serious but rare side effects or adverse effect would be methemoglobinemia, syncope, prolonged bleeding time, dermatitis, and rebound hypertension and thrombocytopenia. But to be honest, I haven't seen this side effects.
world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share. Every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound powered by React's collaborative platform. Innovation and you, Philips.
We use IV nitroglycerin with caution if the patient is drinking alcohol, if the patient has hyperthyroidism, hypertrophic cardiomyopathy, postural hypotension, severe renal impairment, and hepatic impairment. So we gradually decrease dose to avoid withdrawal reaction. And again, as I have mentioned earlier, we may need to give a 10 to 12 hour day, 10 to 12 hour per day nitrate-free interval to avoid the development of tolerance of the IV nitroglycerin. And if we convert it to IV infusion, we remove the topical forms that are given previously. Now, just a few important technical information about this medication. The use of glass bottles and non-PVC or polyvinyl chloride tubing is advised to avoid adsorption of the drug to delivery devices, because if we use PVC, then as much as 40 to 50% of the drug is adsorbed, meaning it is attached to the tubing or the PVC container. So the use of PVC tubing in infusion set may lead to loss of the active ingredient due to the adsorption of the drug to the tubing, meaning and the implication of this is that the dosage is affected because of the adsorption of a certain percentage of the medication. The adsorption is affected by the length of the tubing, the flow rates, and the concentration of the medication. And they are usually delivered fraction of solution's original nitroglycerin content has been 20 to 60% in published studies. So meaning there is a adsorption would affect the dosage of your nitroglycerin. Now, solution containing dextrose without electrolyte should not be administered through the same administration set as blood, as this may result in pseudo-agglutination or hemolysis. And severe hypotension and shock may occur even with small doses of nitroglycerin, especially if they are being given in patients with medications such as sildenafil or tadalafil or other medications that are listed previously. And interestingly, the hypotension that is induced by NTG can be accompanied by paradoxical bradycardia and increase in angina pectoris to a certain extent. This is just to highlight again the nitrate-free interval that we have to consider in giving IV nitroglycerin. Pregnancy and lactation, the category C, meaning the use of nitroglycerin, we use it with caution if the benefit only outweighs the risk of its use, because animal studies of the drug show some risk, but human studies are not available. For lactation, we can give still nitroglycerin, especially for the IV or the oral medications, if only the benefit outweighs the risk of hypotension for the baby or the infant. Now, some pharmacology, its half-life is 1 to 4 minutes, and the onset is 1 to 3 minutes. for the IV. And then the duration is 3 to 5 minutes, and it is protein bound in 60%. So this is very important because it affects the volume of distribution, and it also may affect its degradation if the IV is protein bound by more than 50%. Metabolism is mainly in the liver, as well as in certain extrahepatic sites such as vascular wall, the RBC. And clearance is 5.5 to 11 liters per minute, and it is non-dialysable. These are the different onset of action depending on the route of administration of the nitroglycerin, whether it be sublingual, translingual spray, IV, or intraarterial. Of course, IV is immediate and intraarterial is immediate as well. For the compatibilities of the IV nitroglycerin, they are as an additive, meaning you can combine it in the same container. We can give aminophylline, dobutamine, dopamine, furosemide, lidocaine, and verapamil. For the syringe cocktail, we can give heparin that along with nitroglycerin, and also verapamil is another compatible medication that we can give in the cocktail for use in the prevention of radial artery spasm in the cath lab, as well as in the treatment of no reflow or slow flow phenomenon that I will show to you later. In the Y site, meaning different containers, but they can be administered to the Y connector. Amiodarone, diltiazem, dobutamine, dopamine, famotidine, lidocaine, pancuronium, ranitidine, sodium nitroprusside, streptokinase, and tacrolimus and vecuronium can be given in the Y site. And incompatibilities, we cannot give as an additive hydralazine and phenytoin. And in the Y site, alteplase, which is for thrombolysis and hydralazine. Usual preparation of the IV nitroglycerin is 10 milligram in 90 ml D5 water or sterile water for injection. Sometimes plain NSS is acceptable as well. We start with a dose of 10 microgram per minute, and we can increase the dose as mentioned earlier, ideally in using glass IV bottles and administration set. For intraarterial or intracoronary administration, for the treatment or prevention of radial artery spasm and the treatment of no reflow phenomenon respectively, we can give 50 to 200 micrograms of the nitroglycerin diluted to 5 ml of plain NSS or sterile water for injection. This is again the same medication of the injectable nitroglycerin that I have shown you earlier. Now, for the other uses or other indication of nitroglycerin, hypertensive crisis, radial artery spasm, coronary artery spasm, and coronary slow flow or no reflow phenomenon. Now, this is taken from the recent hypertension guidelines, and as you can see in this table, that the IV nitroglycerin is still the first-line treatment for certain hypertensive crisis, namely acute in the setting of acute coronary syndrome and in the presence of acute cardiogenic pulmonary edema. Now, alongside labetalol for ACS and sodium nitroprusside for the acute cardiogenic pulmonary edema. In the absence of ACS or cardiogenic pulmonary edema, the treatment of hypertensive crisis is the nitroglycerin is already supplanted by other agents such as nitroglycerin and beta blockers, such as labetalol or esmolol, because of their more stable profile and the absence of the nitrate tolerance that has been mentioned earlier. For the treatment of radial or prevention of radial artery spasm, this is a study that has been done in South Korea, which included 400 patients who underwent coronary catheterization by the distal radial artery. And the study is done by Professor Lee in South Korea, and he compared intraarterial NTG with a dose of 200 micrograms compared to the cocktail of intraarterial NTG 200 micrograms plus 2 milligrams of verapamil. So the outcome that was seen in this study is the changes in the mean diameter of the radial artery and the development of radial artery spasm or RAS. And of course, for the safety profile, the BP and the heart rate changes. This is the flow of the study. So about 930 patients were included in the study, but these patients, a certain portion were excluded pre-randomization because of this scenarios. 425 underwent coronary angiography, but only 400 were selected and were randomized to the nitroglycerin and the cocktail group. So the nitroglycerin, again, 200 and 200 subpopulation for the cocktail group. This is what the baseline characteristics of the study population, as you can see, sorry for the busy slide. In terms of their demographics, they are pretty well balanced. As well as their laboratory findings in both groups, pretty well balanced as well as for the medications that have been given to these patients. This is the radial artery in comparison to the NTG group versus the cocktail group, and it is statistically not significant with each other. The change in the diameter is also not significant with each other, meaning, and the development of the radial artery spasm is not significant from each other, meaning this would only tell us that nitroglycerin alone, even in the absence of verapamil, may improve the diameter of the radial artery and prevent radial artery spasm compared to the cocktail of verapamil and nitroglycerin, which is the previous practice of prevention of radial artery spasm. And this is the mean radial artery diameter, as you can see, before giving the nitroglycerin in the left panel or the left figure, and then after there is an increase in the radial artery diameter, and the increase of after administration of the NTG is statistically significant. For the cocktail group, there is also a significant increase in the mean radial artery diameter after administration. Now, if we compare the two, there's no significant difference from each other. So, meaning each medication, there is significant improvement in the radial artery, but there's no significant difference if we compare the cocktail from the monotherapy of nitroglycerin. For the safety profile, there is no statistically significant difference in the drop of the systolic BP comparing the NTG group from the cocktail group, but there is a more decrease in the diastolic BP with the cocktail group. Remember that verapamil and NTG is the composition of the cocktail group. And the heart rate there is no significant difference in the change in the heart rate between the two groups, NTG and the cocktail. So again, this is the study design. This is the successful distal radial approach. And then the population were randomized to NTG group and a cocktail group of verapamil plus nitroglycerin. And the NTG group is nitroglycerin alone, 200 microgram. And for the clinical profile, there is there's no significant difference in the mean change in the right radial artery diameter. There is a more diastolic drop with the cocktail group and no pain in both groups, which is statistically non-significant from either. So in conclusion, for this study, intraarterial injection of NTG alone is sufficient for the prevention of radial artery spasm during cardiac catheterization via distal radial approach compared with a cocktail of NTG plus verapamil. And moreover, NTG plus verapamil or the cocktail is associated with significant decrease in the diastolic BP compared with the usage of the NTG alone. So this is just to show you how we document the treatment of radial artery spasm. So this is the radial artery, which you can see as shown in the arrow. There is a narrowing in the one artery of the arm where this is how we give nitroglycerin we can give 50, 100, or 200 micrograms diluted to 2.5 to 5 ml. And then we give it through the radial sheath. And then after administration of the nitroglycerin, there is improvement, significant improvement in the radial artery. This is for the coronary artery spasm. So the previous one, it's the radial artery spasm. But for this one, it studied the use of nitroglycerin in the prevention or treatment of coronary artery spasm to prevent unnecessary PCI of those who are coronary artery spasm. Remember that coronary artery spasm is dynamic obstruction, while coronary artery disease is a fixed obstruction of the coronary arteries. Sometimes, in the absence of nitroglycerin, patients undergo percutaneous coronary intervention or stent placement, even if they are spastic in nature. So, in which case, in patients with coronary artery spasm, they should only be given nitroglycerin and should not be stented because they are not fixed obstruction or not really CAD. So this study by Professor Partovi included 360 patients with angina pectoris or myocardial infarction who were candidates for PCI. And he gave intracoronary NTG at a dose of 25 to 200 micrograms that were administered intracoronary. The outcome is reduction of the stenosis below 70% of the lumen of the coronary artery. And the baseline characteristic of this study, as shown, is pretty well balanced as for the demographics. But if you can see here, highlighted here, if the patient has STEMI, LAD stenosis, or multivessel disease, they are unresponsive to nitroglycerin already, meaning that obstruction is more of true coronary artery disease rather than spasm alone. So again, this is the angiographic effect, angiographic images of patients with coronary artery spasm. You can see that there is a narrowing of the blood vessel of the LAD. And then after administration of intracoronary nitroglycerin, there is an improvement of the LAD blood vessel. So in this case, there is no need for stenting or percutaneous coronary intervention. But in the CRD, this is a fixed obstruction. This is true narrowing of the coronary artery. So in this case, after administration of intracoronary NTG, there is still obstruction. Maybe this patient would need PCI or stenting. But in coronary artery spasm, there's no need for stenting for that purpose. And they concluded that intracoronary NTG administration can relieve coronary artery stenosis in candidates for PCI and prevent unnecessary PCI or stent placement. And the presence of multivessel disease and stenosis in the left circumflex artery, as well as LAD, as presented earlier, were the independent predictors of non-responders. So meaning if the patient has multivessel CAD and stenosis in the left circumflex or LAD, more likely that these are fixed obstruction and not coronary artery spasm. But you still have to administer NTG in patients with single vessel disease to rule out coronary artery spasm and prevent unnecessary stenting of those blood vessels. So with that, I would like to thank everyone.